I'm Peter Kulchinsky, Managing Partner of RA Capital Management. I'm an investor, a scientist, and a food allergy parent. So food allergies are personal for me, as they are for many. And in each episode of this monthly podcast, I'll be speaking with a dynamic thought leader about the grand human quest to conquer food allergies. We'll explore the science of food allergies and technologies to prevent, diagnose, and treat them, as well as the complexities of public policy, insurance, business models, and simply human behavior that, like many entrepreneurs know, can kill seemingly good ideas. So join me and let's talk to the brightest minds on the planet about the food allergy solutions we already have and what's on the horizon. Welcome to Future in Sight.
All right. Hi, Mariya.
Hi, Peter. How are you?
I'm good. So we're gonna try something new with this Future Insight podcast.
Yeah.
You and I basically just met. We exchanged emails before, and I've looked up your bio, and we're gonna record this session right from the start because we thought that it would be cool for our audience to get to know you as I'm getting to know you. So, maybe it's a good idea, maybe it's not. It's call it an experiment, and how much sort of preparation and choreography needs to go into a podcast episode. So just to introduce myself, I'm a scientist by training, a father of a child with food allergies, and a supporter of FAIR, and professionally, I'm a biotechnology investor. So I manage a firm called RA Capital, and we've made investments in the food allergy space, both on the treatment side and the prevention side. And so I'm now moderating this podcast, Future Insight, to explore this field of food allergies, talking to people who are experts in the space from different angles. So in the last episode, we talked to Dr. Kari Nadeau from Stanford, who is probably the most well-versed researcher on the planet as far as all the different approaches. And I thought, rather than butcher introduction to you, that I would ask you to just describe what's your connection to the food allergy space, to healthcare in general, and what are all the activities that you're juggling?
Yeah, great intro. And I'm very excited about the experiment that we are, or the hypothesis that we're testing here today. The two somewhat of a strangers who have a shared passion for changing things for the better in healthcare could have a exciting mind meld conversation together. First time they meet each other. I am a serial intrapreneur. That's probably the best way to describe me. I have built and scaled businesses in large organizations across multiple industries. Most recently, I served as the serial entrepreneur, also known as the Vice President of Innovation at Anthem. And in that role, I was able to develop a number of digital care delivery solutions that helped patients find care easier, demystify some of the complexities around care, and get care outside of clinical settings. I set up our sensor portfolio, a lot of our work in blockchain. So that's my professional side, if you will. I'm also an activated patient. At times, I am also a frustrated patient. But what that gives me is that grounding of anything I do in innovation or strategy that has to do with technology. My first question is, what's in it for the patient? It's a great technology. It's very sizzling. It's cutting edge. But ultimately, how does it pan out for the end user? So that's the best way to think about me. I'm going to try very hard not to be cornered in one label or another, and let alone take over the representation of the insurance industry as a whole. But I think we'll have a great conversation.
Yeah, Well, I'll throw on you the label of being a Harvard MBA as well, and
Guilty as
you
charged.
majored in economics. So,
There
you
you
know,
go.
I imagine that infuses your sort of big picture view of what are we trying to achieve from a societal standpoint. You know, I thought it was really fascinating that, you know, you are looking at helping patients from within an insurance company, because you know, I think a lot of people think of insurance companies as, you know, being sort of, we take your premiums, we pay your bills, along the way we give you a hard time. But the idea that internally there are people that are studying how do we get better health outcomes, that may not be evident, right? So we're in a very polarized time when it comes to healthcare debate, and you know, it sort of feels like insurance is the bad guy. Tell us a bit about the people, you know, that you've gotten to know within the insurance industry, and, you know, help personalize it for us so that we understand what they bring, like the pathos of the people that are within the insurance industry, and help us understand how you guys perceive, you know, those of you working on solutions for patients, you guys perceive some of the constraints, the denials, the that you know, see insurance, some insurance plans issuing. And I would imagine that, you know, like in any industry, people inside of it don't always agree with what they see their own industry doing. So tell us that story from the inside, if you would.
I love that you're starting with people. I think healthcare is about people taking care of each other. I joined Anthem as an outsider. As you mentioned, I describe myself as a recovering banker and a strategy consultant before I joined Anthem. And the reason I actually joined Anthem was my own personal healthcare experience. I was diagnosed with a giant kidney tumor, the size of a football, that took up half of my abdomen. And it took me 18 months to proactively figure out what's the right path of treatment for me that didn't leave me either bleeding out on the surgical table or with living with one kidney. And that personal healthcare experience drove me to have the need to have a more direct impact on patient care. Now, again, that's still grounds me in asking about who are the people behind the label of insurance.
I got to ask, I just got to interject. How is your insurance coverage through all that? That sounds like it was probably very expensive.
I was very, very blessed and lucky because I did not pay. I mean, I have to tell you, I had a 6-hour surgery with multiple attendings in Mass General, and I had multiple other procedures before that. And
no surprise bills, right?
It was a lot of bills, and it was not, I mean, I paid my copay and deductible, and it worked. Insurance in this case worked the way it was intended to.
Well, when you've got a job, and I imagine, you know, a reasonably well-paying job, and you've got standard commercial insurance in this country, insurance does work,
Yes.
Right? And that's the reality for, thankfully, the majority of Americans. The trouble is, it's not everybody, right? Yeah.
That's the reality of it. And yeah, this is where we need to do a little bit more work collectively to make sure that we're not, that we're incentivizing the behaviors we want to see from patients and physicians and all other players in healthcare. And so from my perspective, when it comes to the people behind those decisions that are being made, I personally gain much better appreciation for the complexities and the boundaries within each of us are operating within insurance. I love it when startups come up and say, we came up with a great new solution and we'll do insurance better. And there's a lot of value in that, but it's much easier when you're doing something and starting from scratch. It's very different when you're trying to navigate decades of legacy infrastructure, systems, legal framework, regulatory compliance restrictions. And so that environment makes the reality of trying different things or moving fast in healthcare overall and insurance very, very different. So
Yeah.
that was the appreciation that I gained as an outsider. That's number one. Kind of the legacy systems and the confines that weren't movable in many ways, at least not in the short term. And the other piece was really the appreciation for people. People go to healthcare and insurance companies, their associates and people joining, frankly, because they want to serve and they're driven by this bigger mission. The first thing I did when I started my role was to spend a week shadowing our call center associates. And the conversations and the opportunity to actually go out of their way to help the person on the other side was really astounding. I can't say that technology was always a friend. Most of the time, they were able to do that despite the limitations of the technology and what was in front of them.
But
so
the call center, I mean, what kind of calls are we talking about? You know, people saying, I've got a healthcare problem, or people saying, hey, how come you didn't pay my claim?
All of the above, right? Sometimes it would be something along the lines of, I just got a diagnosis. I don't know what's included and what's not included. Help. Other calls could be, and without sharing anything that's PHI, other calls could be, I just got a diagnosis. I just divorced my husband. What do I do? Who covers my medical insurance right now? And I've seen situations where call center associates would be on a three-way call with the member and whoever else is needed to solve that equation, right? And it only, again, it comes back to the person, to the human on the other side that goes above and beyond. So that's the second appreciation. There's so much limitations and so many ways in which we should be able to make the lives of those frontline associates better. But at least on a foundation level, that was something that was really surprising. And to me, yeah.
So you shadowed folks at the call center, and then, as vice president of innovation at Anthem, how did you take your personal experience, going through this, healthcare crisis, and apply your own experience to innovating within Anthem? What are some of the projects you've been working on?
Well, we have to be careful how much we go into detail, but I'll give you things that are public now.
Sure.
And it connects directly to some of the questions around allergies and food allergies, specifically how our paths connected. I believe that when we still look at healthcare, we look at it in a very siloed way, that either that pigeonholes us, puts labels on us as a patient and then a diagnosis. And fundamentally, what I've realized from my own personal experience, even the fact that after my surgery, my doctors, brilliant doctors who are top of their in their specialty, in their industry, sent me home with instructions to manage my pain with different opioids, but no one really sat me down to talk about how I should incorporate anti-inflammatory things in my food, how my lifestyle might impact my recovery. What are the choices for me that I need to be aware of so that I could accelerate my recovery, and how I can manage inflammation and manage pain, and how stress impacts my choices and nutrition impacts my recovery. So from my own personal experience, I came in with the intention to try to look at connections across non-clinical interventions and their impact on clinical outcomes, because that's what I experienced as a patient myself. And that led me to, so that's number one, that led me to opportunities to look at how can we create interventions and resources for patients to make the better choice. Not only compliance to their drug regimens, but also compliance with, especially when it comes to lifestyle diseases, compliance with changes in their day-to-day routine. What I also
Oh, sorry, please go ahead. And then I've got a pivot in mind.
Go for it.
Okay, so let's pivot really fully to food allergies. I love that you brought up the siloing, of how we manage, people's healthcare needs. We've got, PBMs managing drug coverage. You've got the payers more directly managing, the healthcare services, right? ER visits are treated as their own thing rather than, part of a constellation of problems a patient may be having, and ways that you might be able to improve their access to a primary care physician to manage their disease so that they have fewer ER visits. I'm on the board of a company working on a sickle cell drug, and those patients go into the ER, with incredible frequency, and a lot of them are on Medicaid, and physicians don't like taking Medicaid patients, so you get these healthcare deserts, and so they show up for care at an ER. Yet I would imagine that a payer would say, hey, we should really build units that focus on sickle cell patients and reduce their use of these expensive ERs, and give them a phone number to call, and a clinic to visit, and try to manage their disease better. So food allergies are kind of like that, right? You get a diagnosis. If hopefully you're well informed, have good enough insurance, you're carrying around an EpiPen or an AviQ or something like that. You may or may not know how to use it on yourself or on your child. If you avoid those foods well enough, you technically have it and may never use it, which means that the first time you use it is terrifying, right? You should go to an ER, but you don't want to overreact. I mean, who wants to go to an ER and spend a lot of time there if they don't have to? And yet, if you don't, you're worried your child might die. I mean, my wife and I have had these experiences. And we're through FAIR, we're now working on a trial, to try and demonstrate whether early introduction of foods containing the various allergens, like starting at age, of 4 months, might help prevent the emergence of food allergies, right? So we've learned that that's indeed the case, through the LEAP study with peanuts. You feed kids peanut butter or Bamba or something like that, it reduces it. But foods aren't covered by insurance, and technically, if those foods are more expensive, if it's more of a burden to buy them, and parents may have a hard time juggling introducing 8 different foods, sesame and shellfish and fish and like all these nuts. I mean, you just want to like feed the kid and get on with your life. It's hard to imagine cooking, preparing all these things. So offering up some kind of guidance, a call center that touches base, or text messages that touches base, shares recipes, maybe even encourages the development of foods that integrate as many of these food allergens as possible so that it's easier to feed babies. All of that could lead to a reduction in the emergence of food allergies, which benefits the patients, benefits societies, reduces the need for ER visits, reduces anxiety, and presumably would reduce those costs for the payer. But they don't pay for counseling parents on feeding their kids peanut butter or tree nut butter or shellfish. You're the VP of innovation. Help us solve this problem. How would you navigate that and make a case for it?
There you go. Here I am in the corner as that we promised ourselves not to put me in as the label of that.
It's too special a label. It's just too, we don't meet people like you who bridge, payers and innovation. I mean, you're the whole package for us. How do you solve this problem?
Happy to have the conversation. Again, I'm an alum in that role, no longer in it, but I will give you my 2 cents. I believe that there is definitely a move in the right direction in healthcare to appreciate the role of nutrition. More and more plans and providers, especially the ones that are in capitated and value-based arrangements, are now looking at reimbursing meals, especially for diabetic patients and other patient groups that are high risk or at a vulnerable situation, right? So in Medicare, Medicaid programs, we're seeing the beginnings of that. Some integrated delivery networks like Geisinger are actually are setting up their own food banks and food clinics, and they're prescribing meals to their patients. Now, that could be a great analog for allergies and food allergies specifically. I don't think we've gotten there yet. I think our collective understanding of, again, nutrition and its impact on clinical outcomes is growing. Policy and reimbursement will catch up. We know that it lags several years to do that. I think COVID has accelerated that. And frankly, the unsustainable cost of chronic diseases has accelerated that understanding. So my actually conviction is that understanding we're seeing in some of the other diseases will transfer in adjacent areas. And what you're describing in allergies makes a lot of sense. But it can't be just the unilateral, okay, from now on, insurance companies will decide to do that. It needs to be, there has to be a CPT code. It has to be aligned with regulatory. You can't afford it only, you can't offer it only in one state and not offer it in others. And that brings in a whole host of, let's call it other departments and teams who need to be in the room when you're making that decision. So
if we do this study and we prove that indeed the introduction of a myriad of allergens into the baby's diet from an early age meaningfully reduces the emergence of food allergies, our hope is that will now become a medical claim that various food producers can make about their foods. You see it now on peanut butter products saying, has been, introduction of peanuts into a child's diet or whatever has been shown to reduce the emergence of food allergies. I think we've seen things like that start to emerge because it's now considered pretty well proven. I'd be curious if you're aware of any insurers that offer that guidance to new parents, saying, by the way, you might want to do this, recognizing that, if they can encourage that, it's going to reduce the emergence of at least peanut allergies, or whether that's still something that's just assumed best left to the pediatrician.
I think as much as we can, at least from my experience, as much as we can, what we're seeing in insurance traditional model is that the care guidance are left to specialists and the providers for no other reason that some insurance still believe that there is some level of, first of all, liability, and secondly, mistrust, that when it comes to your care, that when it comes to their care, patients prefer to get their instructions from their providers and the primary care doctor or the pediatricians. In this case, it's going to be the pediatrician who's have the relationship with the family and the patient. I haven't seen that. I think it again makes a lot of sense to put it out there, but it's in the grand scheme of things, it's it will make a big difference, but it's not the typical behavior that we would see from insurance companies. I almost envision you and I writing a manifesto of here are the 10 things that that don't cost much, easy things that insurance companies could do to prevent long-term utilization or adverse outcomes. Yeah.
So I definitely think that the FAIR folks are going to be calling you up, to follow through on that. That sounds like a great idea, because we've absolutely got to.
And it could be an open source memo, and people could be adding in, and we could make it very, very specific, right? Nothing that's, the way I described my role in the time that I spent in Anthem was defining the short-term ROI of long-term thinking. A lot
ROI, return on investment.
Return on investment, because a lot of our incentives in the system, the way our system is designed, incentivize episodic transactions, be it from the fee-for-service system or anything else that we see as some of the publicly traded companies do it today. So the ability to translate, yes, this is a longer term view, but it's something that you need to implement today, because these are all the additional ways in which you would benefit today. Makes a lot of sense.
Okay, so I'm going to go down that rabbit hole with you of economic speak, because I think what you just said is the most important thing ever to have been spoken on any podcast in the history of podcasts.
I know, we're only 15 minutes in, so let's see what else we can.
So here's the thing, right? As a species, we have internally operated, with an absurdly high discount rate, right? Which means that whatever benefits we may want, 20 years from now, we basically act in ways that suggest we don't really care about those benefits. We're so focused on, optimizing things in the near term as a species, at a biological level, it would seem, right? And as we've built out communities, developed governments, as our lifespans increased, there's always been this effort to figure out, how do we motivate people to truly act in a way that is consistent with caring about the future. In other words, reduce your discount rates so that things that are 20 years out actually mean some matter today, right? We talk about the private sector has a fairly high discount rate. I got to get my return, an 8% discount rate or something like that. Might go into a business's net present value calculation of, should we spend money now and will we generate enough revenues in the relative near term? Patents give you 20 years in which to profit, and then the patent expires and presumably your product gets commoditized, and you think, hey, it's 20 years, that's plenty, right? But society wins in the long run because they get all this innovation that goes generic, essentially, becomes a commodity. I'm curious, what is the internal discount rate for insurance plans, for insurance companies? Is it more the private sector, businessy, 8-ish%, or is it more a societal discount rate of 1.5 to 2%?
The more frequent question that is being asked is, what is the duration over which I should expect to make a return on my investment? And we all know that the average lifetime spent of a member with a health plan is about 3 years on the commercial side. And so a lot of the calculations are within that 3-year horizon and time frame. At least from where I've have the purview of looking at things, the 20-year horizon is not necessarily something that we all that we get together as a societal level and even at an industry level and discuss. That's actually part of the, and maybe some of the forums in which these conversations happen actually are not being used for that purpose. Because at an individual organization level, the priorities are slightly different. And so, yes, the internal rate on return is much more focused on, is this the right thing? Is this compliant and regulatory sound? And then how does that look like for us in 1, 2, 3 year horizon?
But then that means that it's impossible to make a return on investment argument for any of the kinds of stuff that would prevent, costs and pain, more than 3 years out. It would argue that you couldn't justify to a payer why they should pay for a drug to treat hepatitis C when it'll plausibly prevent a transplant, in 15 years? It's like, oh, I won't have that patient. But how come everyone's concerned about only their patients when, it's kind of like musical chairs out there? Those patients, they leave you, they go to someone else, but then somebody else's, some other insurance plan's patients, they come to you. So is there a fear that if I do something noble and good to improve the health of my patients, that the other insurers won't? And so they're just going to cycle their sick patients to me while I export my healthier patients to them?
Yeah, I mean, it's the free rider problem, right? If would others benefit from the investments I'm making now? I think that philosophy and that thinking is slowly probably changing, but again, it goes back to you get what you incentivize. And in the current state, the way we have designed the system, that longer term thinking at scale is not encouraged. It just doesn't add up. What I do think is interesting is there is a broader appreciation, I believe, in driving again, you make a make a great argument in your book about insurance companies being incentivized to grow the pie, which is counterintuitive in many ways. But because of the way the system is structured, there's this thing called the medical loss ratio, which accounts for the medical cost for members. And then there's on top of that administrative fee. So if you're truly optimizing only for economic returns, you truly want your overall pie of medical costs to be growing. One could make a similar argument for pharmaceutical companies, irrespective if it's branded drugs or generics, as long as the overall spend on pharmaceutical on drugs is growing, the industry is growing, that's a good thing. I do believe that all of us, and we shouldn't be pointing fingers only in one side of this complex ecosystem. I do believe that we are all somewhat over-reliant on pharmacological intervention or any other medical intervention, when a lifestyle change might also be a good tool in our overall toolkit to use. So we can't necessarily treat some of the cancers and neurological conditions with lifestyle changes, weight loss, cessation of substance use, etc. But we could, in many cases with some of the chronic diseases, actually do that and see real management and reversal in some of these cases. So
how do we do that though? Because you're right, but to some extent, I actually grapple with this a fair bit. Obesity is a huge contributor to a whole variety of diseases. Generally, we're all told, look, you got to have a healthy diet and you got to exercise. Some people just cannot manage their weight no matter what. They try. In some of those people, we've actually identified genetic reasons for why they have a predisposition to gaining weight. So by most people's standards, it's like, oh, well, then you're the exception. But everybody else for whom it's not genetic, it's your fault. And yet telling people it's your fault, making them feel bad about themselves, if they have low willpower or whatever, it kind of ignores the human condition. Life is hard, like we didn't evolve in a world where food was so plentiful. We evolved in a world where we were lucky if, anybody managed to get a full meal. Like you weren't really at risk of becoming fat. And if you could become fat temporarily, it might help you get through a winter, So we're burdened by, our evolutionary past, I would argue. And we're trying to construct a framework in which we can still live life despite the fact that certainly for some people, it can be hard to keep the weight off. So rather than think of lifestyle as being code for it's your fault, fix your lifestyle, how can we take what we've learned from, physicians or payers helping to manage diseases that are not seen as a lifestyle issue, but where counseling, helps patients prevent as much as what they can prevent, and manage their disease as well as possible, and apply it to things where lifestyle changes are merely part of the toolkit. Do you see payers playing a greater role in encouraging and these lifestyles, and how? Do they pay you to lose weight? Do they buy proper food for you? You mentioned Geisinger does that. What are all the things we might see payers do to help work in lifestyle improvements?
I love the question. I think there's a lot of work and a lot of encouraging activity in that area. The answer is it depends, and it's very personal. The right answer is personalized and, in my opinion, hyper-local. Health is local. Health is personal. So we can't say that paying people to quit smoking is the best way to do it. For some people, rewards work. For others, it's peer pressure, it's community, it's collaboration, it's positive reinforcement. And the way that happens is we're seeing health plans in conjunction with providers putting together management programs, condition management programs. I'll tell you that some of the programs that I've seen around, let's say, compliance or taking your drugs for managing hypertension or any cardiac conditions are now coupled very tightly with mental health in interventions. So for example, you could send as many alerts or phone reminders to the patient to take their medication three times a day. But if they are not motivated to do it, if they don't have a reason to stay healthy and get healthy, that's not going to happen. The biggest driver is when you couple that with a conversation around, hey, do you want to get healthy so you could go see your grandchildren? Do you want to get healthier so you could participate in your local church and the activities that are going there? So addressing depression in cases like this actually impacts their compliance with their hypertension medication. And so that connection is happening. It's happening very often, and it's happening under the title, the umbrella of mental health initiatives that are coupled with some of the chronic disease management initiatives right now.
And so these are things that are going on inside payers. They're identifying patients that are having adherence problems and making sure that they have access to mental health counseling if they need it.
That's
so
right.
In what form does that happen? Do you get a call from your insurance rep saying, hey, how are you feeling? Like, can I make it easier for you to get reimbursement for counseling? Or is that a call that the doctor is getting from the insurance plan being like, hey, we figured out you've got this patient who is really high cost to us. We think there's an adherence problem and we want you to manage that patient.
It really depends. That's the unfortunate, it depends. In some commercial plan arrangements, sometimes the programs are coming in through the employer, in addition to what a health plan would be included in your plan. And so you might not necessarily get a call from your employer because they don't want to have personal information on you, but you would get a call or at least an outreach sometimes directly from the program. So if that program is administered by a third party, they would get access to the members who are eligible, and you would get an outreach. Now, that's either way. I think what you're getting at is that there is probably a little bit of work to be done for a higher awareness from patients that they are these resources available to them. That's number one. Number two, even in our best effort, when you get an outreach from, let's say, a mental health resource of some sort, what happens is the mental health resources are not always talking to the chronic disease management program resources, and so there's still the need for that. Who has the patient holistic picture at heart and who has a full view of that patient, not only longitudinally from their medical history, but at a journey level of all the touch points, all the providers, digital therapeutic companies.
And who does? Who has that? Is there like a person that stays at an insurer long enough to get to know you? Is it that there's a really good record of you that as people move in and out of that role, they quickly look you up and they get a snapshot of who you are and they take over that view? Or is it expected to be your doctor?
Well, unfortunately, in some cases it's expected to be your doctor, but what you're describing is a deficiency in the system. I've always said that complexity is a business model. What you're describing is the reason why so many companies exist in healthcare today, and they do care coordination, patient advocacy, and other services. In an ideal world, there would be currently there is such a role as a case manager in a health plan, and that's the closest we could see where the case manager could pull up the file for that patient and see what programs are these patients eligible for. The challenge there is that frequently there's a lag between the data that a provider has and the data that the health plan has. And so even case managers sometimes don't get the full picture of, hey, I saw that you're eligible for this program. I saw that you had an appointment. Mariya, did you make it to your mammogram? right? So the case manager needs to actually fill in some of the blanks, if you will, from the patient, which is not the best patient experience, right? So you're getting a call from somebody who's supposed to have the full picture, and they don't always have it, because that's, again, going back to what I was describing earlier, legacy systems that are not designed to talk to each other, and that takes a little bit of integration effort.
So, yes, I actually just remembered, I looked up the prior authorization form for Palforza, the AMU, now Nestle peanut allergy treatment. And it asks the patient's age. And it's like, shouldn't that be in the electronic health record? Why do you have to ask a physician to fill out a paper form? I'm curious, is there, have you seen work done to try to make prior authorizations more sort of just confirmation tools and less a source of friction and deterrence to a busy physician being able to prescribe the drug?
Yeah, absolutely. There's a lot of work in that place, from anything from technology where, well, you know that one of the use cases for a medical student was the scribes, right? They would come in with a physician and they would take the notes during the appointment, and then they would have the glorious job to actually do all the back end processing of the paperwork. I've seen anything from taking technology to have like a device in the patient room that records and then auto-populates the fields in the EMR, to other things that are much more kind of a pre-populated integrations with Epic and the EHRs. The piece that, in my opinion, a lot of the tech-founded solutions are missing is that if you automate step 1, 2, and 3 without actually taking into account what happens with without following that prior authorization form through all the different stages of approval, from submission to acceptance and all the other kind of regulatory review steps that it needs to go through, you're automating step 1, 2, and 3, and then you're creating a backlog in step 4 to 5, right? The challenge with adoption of technology in healthcare is always our ability to adapt our processes and back-end operations to catch up with the speed of what the technology could do, right? And so that's why we're seeing less of meaningful simplification and adoption of technologies and scale, because first of all, not everybody has visibility across all the steps, and you have to actually line up all the different partners. Even for prior authorization, you need to understand what the process at the provider looks like, on the patient side, on the insurance company, on all the other data feeds that the insurance company needs to look up to approve that. And so that's something that, again, it's not as easy as, okay, well, I have a NLP engine or natural language processing engine or voice recognition engine or whatever it is that's going to capture the data from the physician. That's the easiest part.
Is the complexity for a physician to be able to prescribe an expensive treatment, is that a feature or a bug?
I know exactly what you're asking. I think there is very little premeditated deterrence, because I think in order for that to be operationalized, you give these large organizations too much credit in many ways.
So it's a convenient bug.
It's an intended consequence that happens, and it's typically what I've seen is that rules are put in place with a specific behavior in mind, and they're not necessarily thought through with all the implications of the different situations that they might apply. That's the challenge of rules-based anything. And when it comes to policy decisions in insurance companies, you have to follow precedents, you have to follow regulatory. So a lot of these decisions and policies are so broad that there's way too many cases that don't necessarily apply with what the intention of the rule was.
So I've been exploring this idea that I think a lot of drugs these days are a lot more onerous and sophisticated than drugs in the past. And the idea that patients would seek those drugs, should be revisited. That, people would overutilize those drugs. Cancer drugs. You don't fake cancer in order to get those drugs. You don't fake diabetes to try to get a prescription for insulin so you can inject yourself every day. You've got to ask the question, why do we need to have patients have skin in the game, with out-of-pocket costs in order to deter overutilization for drugs that you'd have to be insane to actually want to take, right? Side effects, et cetera. So I'm curious, why at the very least, when drugs are, or any treatment really, is prior authorized for a patient, they confirm, yes, you have a tumor on your kidney, or yes, you have diabetes. Why are there still out-of-pocket costs that at least we know some Americans can't afford, and therefore they forego what is now deemed to be appropriate therapy, not just by your doctor, but by your own insurance plan? Shouldn't we have, at the very least, a rule in this country, much like we have a law that says you cannot discriminate on the basis of pre-existing conditions, a law that says if you prior authorized the drug and confirmed it's appropriate, or really any treatment, you cannot discriminate against people based on their emergent condition by charging them out-of-pocket costs that they may not be able to afford. Is there merit to that? And might we find allies within the insurance industry that would agree with that?
I think that might be one of those suggestions that goes on the list, the suggestion memo. I think that there is definitely a appetite to simplify processes and access, if you will. So pending some legal review, every time, I'll tell you my experience, every time I've uncovered something that felt counterintuitive to me, the answer was, the answer was twofold. Number one, it's that way because it's always been that way. And so that's an answer that you could take on. And with evidence, you could change. And the other option for the answer is, it's mandated by regulatory standards. And in order for us to do anything there, and it doesn't have to be anything that's explicit, but it could be something like, if you're removing copays in this situation, you would also have to remove it in another situation that's less desirable. And what I will tell you is that there have been studies where in the Medicaid population, a health plan in Orlando studied the cost by per the individual per patient cost of patients who had a copay and patients who didn't. What they saw was that there was, frankly, per patient overall cost there was no change. There was just shifting in the type of the cost. So for those patients who had a copay, they had lower visits in the specialist, obviously, and preventative care, but they had higher outpatient costs and they had higher utilization in the emergency room. And so what we're seeing, there is some evidence that copays are not necessarily, providing skin in the game, or they're not there to lower overall cost. They just shift where the patients are using it.
I did note that a number of years ago, not that long ago, I think Anthem, but I think maybe other payers said, you know what, we're going to review ER visits. And if it turns out that your ER visit was not a real emergency, then we'll send you the bill for it. And I thought, and there was a big objection to it. I'm actually curious whether that was ever revised, but that has a real impact on people with food allergies. Because when you start feeling something, when your child starts reporting, my throat feels odd or whatever, and you take them into the ER, after the fact, sure, somebody could say, well, that wasn't a real emergency, here's your bill. But in the moment, you had no idea. And, you might have, again, people don't love the ER. I mean, who the heck wants to spend their time there? So I wouldn't say people go seeking the ER routinely. But now this idea that you may get stuck with a many $1,000 bill strikes me that that's going to deter people from going in and getting a last resort evaluation that might save their life. Can you imagine if a fire department said, if we feel you could have put this out with a fire extinguisher, we're going to send you the bill for our visit? And so people don't call the fire department until the fire's so out of control that at that point, the fire department can't even save your house or your lives. And so you wonder, just, is it appropriate, to send a bill to people who show up at the ER? Because after the fact, with all the knowledge that you gained from the actual assessment of the patient, you were able to say, well, that wasn't a real emergency. What if that money were spent on having one person stand there in the foyer of the ER, and if they can spot, it's like, this isn't an emergency. Like, seriously, you need a Band-Aid. I'll put it on myself or whatever. Here's a pack of Band-Aids. Well, fine, you can avert that, but don't use the
I'd like to see that
pills.
even sooner, right? I'd like for us to have the ability, for us as a medical community, to have the ability to triangulate the environment. First of all, find the patients who are at a higher risk of an exacerbation, knowing that they are diagnosed with food allergy, and being able to triangulate between frankly, even their environment, their exposome that tells us. We know that pollen rates, air pollution, we know that exhaust rates in the air or where they are geographically might actually have an impact on the risk that they might have. So for me, ideally, we wouldn't wait for people to go to the emergency room. We would be able to send a notification, frankly, even at the beginning of the day, that says, Mariya, in your neighborhood, not in Boston, in your specific neighborhood, in the radius of 2 to 3 blocks, the air quality and the allergy risk factors for you, given that you might also have asthma in addition to food allergies, which is very, very likely, today doesn't look so good. So plan your commute, plan your workout accordingly. And I think that's the vision that I subscribe to. So we don't get to argue over, was that a good visit? To me, we need to give enough data points for patients to make educated decisions at the time when they matter the most. Because that panicky moment when you're feeling off or your child is not feeling well and you're making the decision, you would always err on the side of caution.
Well, I would love to take you up on what maybe was an offer, to pull in some folks to brainstorm. How could we have insurance without out-of-pocket costs, right? So that indeed there are other ways of guiding people to appropriate utilization, but when it's deemed appropriate, money doesn't stand in the way of your ability to access. But that's something we can talk about offline. One final question. When we talk about these silos and the fact that people will leave after 3 years, so it's almost like silos by type of care and silos in time, right? Is there merit to universal insurance and a single healthcare system across the whole country so people just stay in a single EMR? Or from the inside, is there, do you have insights that might make people more cautious on that utopian approach to health insurance and healthcare?
Are you asking this question as an economist, in an abstraction of not living in the US?
No. Very much as an abstraction, it sounds great.
Yes.
But I'm not an economist, you're closer to it. And we've all learned that behavior is a very real problem in, achieving anything that sounds ideal. Tell us a bit more about the reality, and then, just in 2 minutes, the final 2 minutes, those people that subscribe to the idea of universal, insurance, a single insurance plan, and, making the entire country Kaiser or something like that, what should they know about the realities that might make them think twice, or are they right?
I think the question you're asking is a choice that's based on belief systems, and those belief systems allow us to make the trade-offs that we have to make. none of these systems is perfect or without its glitches. And because of our own personal beliefs, we are able to deal with the glitches better, right? Some could argue a universal health system, and I lived in London, I was a recipient of the NHS service. Some folks could argue the NHS is fantastic. Others would say, and they'll point to the systems in Canada and say, I don't want to wait 6 months to get surgery, right? And there are some trade-offs, right? You will have to go to the provider that you're assigned to. There's less of a what some people would say choice, and you have to wait longer. I think that this is a debate that cuts at the crux of what's our belief system and what we.
Do you think that it's inherent to a very large system that it's going to be difficult to avert 6-month delays, or could one imagine, a system in America where you have a single health insurance plan, a single EHR, and you don't have to wait 6 months and you can choose different doctors?
Absolutely, you could design it. Absolutely, you could design it that way. I believe that there's a way for this to be operationalized, but I also think that it will come with trade-offs and cost. I believe one way or another, we are paying for our health system and for the uninsured, for the cost of the uninsured patients, right? Through taxes, through higher bills in the emergency room for those who are insured, we are bearing the cost. And in many ways, it's just shifting the cost from the less obvious channels to a more direct funding channel. But that, again,
and we have pockets of it too, right? For those people in the Geisinger system, they may as well be living in an integrated, all-inclusive system, and same deal for Kaiser. So it's not like we don't have it. We can study the pros and cons of these systems, and then whether you can scale that to the whole country without the sheer bureaucracy caving in on itself, that sounds like it's a challenge of building an organization of people.
We should prize a competition around it and see what happens.
Indeed.
Yeah.
Well, Mariya, this has been a fascinating conversation for me, and I'm looking forward to continuing it with you offline. Thank you very much for joining us.
Yeah, great to meet you.